Good morning, everyone. Today we'll be talking about the diagnosis and management of mandibular fractures. Okay, so I'll just go through the contents. We'll be going through an introduction about the basic development and anatomy of the mandible, the epidemiology, the etiology of mandibular fractures, the classification systems. There are different classification systems of mandibular fractures. We'll discuss the clinical features and diagnosis and radiologic features of mandibular fractures, and we'll end with the different treatment modalities that are present for mandible fractures. Now, mandible is one of the most complicated bones because of its mobility, the growth, and function. Now, the mandibular fractures constitute to a major portion of fractures in the facial region. Now, the mandible develops downward and forward from the condylar process. And the condylar process is considered as the growth center in mandible, and it develops from the Meckel's cartilage. So this picture gives you a better idea of the growth direction of growth. Now, in infancy, the patient will have a small condyle, a flat condyle with a lack of condylar neck, and as it grows, the mandible moves downward and forward. No, mandible is the largest, heaviest, and strongest bone on the face. The normal mandible provides a good airway and good facial contour. It gives a good aesthetics to the face. Now we'll start at the top, the temporomandibular joint, which forms the articulation of the mandible to the cranial base. Now it has different types of movement, being translation and rotation in the glenoid fossa. The temporomandibular joint is supplied by the inferior artery, and the periosteum of the mandible itself is supplied by the peripheral blood supply. Now, nerve supply is by the inferior nerve, which innervates one half of the dentition and exits at the mental foramen, supplying the chin, lip, and soft tissue. The lingual nerve runs just inferior to the alveolus in the supraperiosteal, in the area of the third molar, and it supplies the anterior two-thirds of the tongue. Now coming to different muscle attachments. Now the four muscles of mastication, the temporalis, masseter, medial and lateral pterygoid muscles, are the muscles of mastication that are attached onto the mandible. On the lingual aspect of the mandible, we have the geniohyoid muscle, the genioglossus muscle, the mylohyoid muscle, and the anterior belly of the digastric. Now, we'll come to mandible fractures itself. So the most common etiology of mandibular fractures are road traffic accidents. When you have a bike accident or a car accident and you hit your chin or your face, mandibular fractures can happen very common. And one other cause is interpersonal assaults. Sorry. Now, work-related injuries from machineries can cause mandibular fractures. Fall. When the patient falls on their chin, that can cause a mandibular fracture. Sports-related injuries, and also pathologic fractures. When the patient has a large cyst or tumor on the mandible, this can lead to a fragile bone, and that can cause fracture of the mandible. Now, the classifications are of different categories, and you need to know at least 4 or 5 classifications for your exam point of view. Now, there's a general fracture classification based on the anatomic position of the fracture, the completeness of fracture, whether it's a complete fracture, an incomplete fracture, or a green stick fracture. Okay, and regarding the mechanism of injury, the number of fragments in the fracture, the shape of the fracture, the direction and favorability for treatment, the presence or absence of tooth, and finally the AO classification of the Association of Oral and Maxillofacial Surgery classification. First, we'll come to the Kruger's classification. It is classified more broadly into simple, compounded, comminuted fractures. Simple fractures are closed fractures. They are linear lines of fracture that do not have a communication with the exterior surface or the skin. Now, compound fractures are communicating intraorally or extraorally. There is a tear of either the mucosa or the skin. And comminuted fractures are in which the bone is crushed into multiple pieces. Okay. Then there are complex, complicated fractures in which the fracture involves the adjacent nerves or major blood vessels, and impacted fractures when one fragment is impacted into the other fragment, and there is no movement of either fragments. Then green stick fractures, which are more commonly seen in children, they are fractures in which only one cortex is broken, because children have more spongy bone. Their bone is just calcifying. They're in the process of calcifying. So they more commonly get green stick fractures. Now, the last one, the pathological fractures, is a spontaneous fracture that occurs due to normal movements of the muscle while chewing or opening the mouth. Patient can have a fracture, but this is due to the weakness of the underlying bone. The causes can vary. It can be a cyst, a tumor, an osteolytic lesion. So the bone might be hollow, it is weak, and it will fracture. Okay. Now coming to the Dingman's and Natwick's classification, they are based on the anatomic frequency of mandibular fractures. Now the body has the highest number of fractures. It is about 29.5% of fractures of all mandibular fractures occur in the body. Angle has about 27.3% fractures. Condylar fractures are about 21.1%. Symphysis fracture 19.5%. Ramus fractures 2.4%. And the least amount of fracture is seen in the coronoid, which is 0.2%, because this is not a weight-bearing bone. Again, you can see that it is classified into symphysis fracture, canine fracture or the parasymphysis fracture, body of mandible fracture, angle fracture, ramus fracture, coronoid, condylar, and dentoalveolar fracture. Now, dentoalveolar fracture, it basically means that the tooth-bearing area of the alveolus is fractured. Now, according to direction and favorability of treatment, it can be a horizontally favorable fracture or a horizontally unfavorable fracture. Now, in a horizontally favorable fracture, the fracture line runs downwards and forwards, and there is no upward displacement of the segment. So, the fracture is such that there is no displacement of the two segments. So, that is a horizontally favorable fracture. Now, a horizontally unfavorable fracture means that the fracture line is running downwards and backwards, and an upper displacement of the posterior segment is seen. So you can see in the pictures here, on the right hand corner, you can see a favorable fracture in which the masseter is splinting the fracture together. There is no displacement. Now, if the fracture is away from the masseter, it is anterior to the masseter, that means the masseter muscle will pull the fractured posterior segment away, and that is a horizontally unfavorable fracture. Now, then there are vertical fractures and vertically favorable fractures and vertically unfavorable fractures. Vertically favorable fractures are when the outer buccal cortex, the fracture line runs from the outer buccal cortex to the lingual backwards. So, a medial displacement. There is no medial displacement of the fractured segment, the posterior segment. Now, the outer cortex is, the fracture is anterior and the lingual fracture is posterior. Now, if the outer cortex is fractured backwards and the oblique line has the lingual plate fracture anteriorly, that means the posterior segment will just rotate medially, and that is a vertically unfavorable fracture. So, in vertically unfavorable fractures, you can see that there is no medial rotation of the posterior segment. Now, next is Kazanjian and converse classification. It is based on the presence or absence of teeth. Now, class 1 is when there are teeth on either sides of the fracture line. These can be monomaxillary fractures. Now, they can be treated with a single jaw treatment. Class 2 fractures are there is teeth only on one side of the fragment, and the other side is edentulous. Class 3 is in an edentulous patient. Edentulous fractures are treated with either prosthesis like gunning splints or due to an open reduction. We'll come to all that later. Now, according to AO, the fracture, there is different kinds of classification, and this is what decides our treatment plan. Now, F represents number of fracture fragments. L is the location of fracture. O is the status of the occlusion after the fracture. S is soft tissue involvement, and A is associated fractures. Now, coming to F for the number of fractures, there is F0, which is incomplete fractures. F1 is single fractures. F2 is multiple fractures, and F3 is comminuted fractures. F4 is fracture with a bony defect. So some bone is lost from that region. Now, according to location of fracture, they can be pre-canine fracture or the symphysis region of the mandible. There can be canine fracture, that is along the region of the canine teeth on either side. There is post-canine, that is after the canine from the premolar region to the third molar region. It can be an angle fracture at the angle of mandible, a supraangular fracture above the angle but below the condylar neck. It can be a condylar fracture, a coronoid fracture, and alveolar process fracture. And alveolar process fracture means a dentoalveolar fracture. Now, according to the status of occlusion, there can be no malocclusion, there can be a malocclusion, or it is an edentulous mandible in which we cannot assess the occlusion. Okay. And last one is an associated fracture. That is A0, there is no other associated fracture. A1 is the dentoalveolar fracture associated with the mandibular fracture. A2 is nasal bone fracture. A3 is zygoma fracture. A4, 5 and 6 are B4, 1, 2 and 3 fractures. So along with this mandibular fracture, you have a maxillary fracture or a nasal fracture along with it. So that also needs to be considered into the treatment plan. Now, A, or the analog classification system of mandibular fractures. In this, each component is classified individually. I already told you about what each component are, and the degree of displacement and the defects are considered. And these are classified into type A or not displaced fractures, type B or displaced fractures, and type C or multifragmentary fractures. Now, this classification system was suggested in the International Journal of Oral and Maxillofacial Surgery in 2008, which it is more helpful in treatment, deciding the treatment. I think we'll stop here for today, and we can discuss